then let me know. Huh? Can you see my slide?
Yeah, can.
Okay. All right. So today we're going to talk about crossbite again. So I think we can skip this because today is the revisions. So we don't have to go through every slide. Huh? But you should able to define, then identify, then classify. And at the end, you have to formulate the treatment plan of the management of crossbite. So first, you have to define what's a crossbite. And second, you have to identify, when you check the patient, do the ENT, you should be able to identify the crossbite. Then you can classify anterior, posterior, or unilateral, bilateral, then whether the dental, skeletal, and later you're going to formulate the treatment plan, how you're going to treat that. So crossbite is a term used to describe the abnormal occlusion and transverse plan. So we talk about the malocclusion can be the AP, transverse, or vertical. There are 3D, so we have to look at it one by one. So crossbite, we are talking about transverse normal occlusions. So the term also used to describe the reverse overjet of one or more teeth. So I think IOTN the last week or no 2 weeks before we talked about the reverse overjet. So we are talking about reverse overjet when there are 4 incisors involved for IOTN. If less than 4 incisors, then we define it as a crossbite. So what's the definition? There's so many. You just choose whichever you prefer. So crossbite can be a discrepancy in the buccal-lingual relationship of the upper and the lower teeth. So when we're talking about crossbite, we always refer to the lower occlusion. So we're talking about buccal crossbite. It's a buccal cups of the lower teeth. You see, they always refer to lower teeth. Buccal cups of the lower teeth occlude buccal to the buccal cups of the upper teeth. Then we are talking about lingual crossbite or scissor bite. It's a buccal cups of the lower teeth again, occlude lingual to the lingual cups of the upper teeth. So we are talking about the lower teeth, not the upper teeth. So again, definition so many, you just choose whichever you prefer. So Grapper is one of the famous orthodontists. So he defined the crossbite is a condition where one or more teeth may be abnormally malposed buccally or lingually or labially with the reference of the opposing tooth or the teeth. So I think in this case, we are talking about lower teeth, whether they occlude buccally or lingually compared to the upper teeth. So there are 2 buccal or 2 lingual, also called crossbite. If there are 2 buccal, then we call it buccal crossbite. There are 2 lingually placed, then we call it lingual scissor bite. So crossbite is the type of malocclusion in which the mandibility, like abnormal buccal lingual relationship with the maxillarity. Same with the first one. So classification with so many. So basically we can base on the locations and anterior or posterior. So single teeth or segmental anterior. Anterior can involve one or single tooth, which is a central incisor or lateral incisor, or it can be the segmental, which involve more than one teeth. It can be incisor or the incisor, or it can be the canine, Depends on the severity of the skeletal pattern. And posterior can be unilateral or bilateral. So unilateral can be the single side. Bilateral means both sides, involve both sides. So single or unilateral, a lot of time they have this displacement or functional shift. Then they should have an initial contact. Then the jaw might be shifted to left or right. So you have to be careful. When it comes to functional shift, like I say, they are considered emergency. Then you have to intercept fast before the jaw is fixed into one position. So again, based on the natures of the crossbite, so it can be skeletal. So we know the castri skeletal pattern, they are prone to this crossbite, anterior, posterior, unilateral, bilateral. So if the jaw is too long, then they always cause a crossbite. So we know the upper jaw, there should be a bit bigger than the lower jaw. So upper teeth should be occlude outside or they cover the lower jaw about 2 to 4 millimeters, which is considered the normal overjet. So if this relationship reverse, then it's considered crossbite. So the more severe the skeletal tree, then the more crossbite is going to be. So let's say just a mild skeletal tree, then maybe just anterior crossbite, involve 1 or 2 teeth. But if they are severe skeletal tree, then maybe they involve 7 to 7, the whole jaw is in the reverse bite. So of course, we have a dental crossbite, which is easy to correct. And if a skeletal crossbite, which involves the jaw, is difficult. So dental crossbite usually involve 1 or 2 teeth. They're in crossbite. The most classical features is the lateral incisor. So the lateral incisor is always palatally displaced then compared to other teeth. And this one is easy to correct if they are just a dental crossbite. Skeletal crossbite then usually involve more teeth and maybe incisor to incisor or 7 to 7 if the severe one. That's difficult to correct. Functional, and as you mentioned before, the patient usually have initial contact, and the jaw will shift to the left and right, or front or back, then that's considered functional. So functional crossbite is considered urgent in orthodontic. Then if you notice there's a functional shift or displacement, then you should correct it early. Okay. So this one is the typical anterior crossbite. Crossbite anterior, the first pictures. And second picture is posterior and crossbite. So on this picture, on the bottom right, there's a crossbite on the right side. Unilateral. Of course, you can have
the slight change is a bit delay.
a bit delay. Okay.
Yeah, now we still now it's only moved to the pictures.
Okay.
I'm not sure.
All right. Thanks for letting me know. Maybe I just try to log in again, see whether you're back.
Okay.
Can you see my slide?
Okay.
Okay. All right. Okay. So unilateral and bilateral posterior crossbite. So which one you think is more easier to correct? Unilateral cross or bilateral?
Bilateral is easier.
Not really, huh? Not really. Bilateral, why you think it's more easier? It's easier. Why you think?
I thought maybe can expand the maxillary jaw so both can settle together.
Yeah, in that point, maybe yes, because you can do symmetrical expansion. So unilateral, sometimes you just have to expand one side. So sometimes it's difficult to control compared to bilateral crossbite. But it's not always the case. Sometimes bilateral crossbite, if you're not careful, halfway through the expansion, you might convert the bilateral crossbite to unilateral crossbite. And the patient can have a functional shift to one side. So not easy. Not easy. I would say both sides are not easy. Both unilateral or bilateral are not easy. So it depends on the case. We can look at some cases later. So typical. So if you're class 1, then you consider mostly, most of the time is dental crossbite. If the skeletal, either they're class 2 or class 3, that's considered skeletal crossbite. So typical example is a class 3. Look at these pictures. So you can see the severity of the crossbite is quite bad. And patient have the anterior crossbite that extend all the way back to the posterior teeth. So in this case, we have unilateral posterior crossbite on the right side. But the left side, you look at the left side, the buccal occlusion, they're okay. The left side is not in the crossbite, but right side is from the 7, then up to the upper left 2. So this one considers severe crossbite. She involve the jaw, which is class 3, then can double confirm with the cath X-ray. Like I said before, if you do the E&D, you'll notice a patient class 3. And sometimes if they are not too obvious, then you need the X-ray to confirm your finding, just to verify everything. So castri, they always tend to have a tendency to have crossbite, whether it can be anterior or posterior, depends the severity of the of the skeletal. Then if they have a class 2, then sometimes they have a scissor bite, the other way. So this one castri, you can see the jaw is asymmetrical, then the jaw is shifted to the right side. So you see the crossbite is on the right side mostly. You can see the right side, the whole jaw is in the crossbite from the anterior and to the posterior. And the left side may be a little bit, maybe a little bit. So again, this one is a castri, when it be the asymmetrical jaw. So the simple one can be dental, usually involve 1 or 2 teeth, then we should consider simple. Like this example, it's just an incisor. So you see the central incisor in crossbite, only single tooth, and sometimes causing some functional shift or displacement, or they cause a gingival trauma or displacement, and this one considered urgent. You should intercept faster before they cause more damage to the gingiva or cause morbidity to the other teeth. So if you leave these positions or crossbite, sometimes not only the teeth will be mobile, they also cause attrition to the upper and lower teeth. This is a typical example for functional shift. You see the patient managed to achieve what we call the HH incisor relationship or HH bite. Then the jaw will shift forward. So this is considered functional shift. So if you correct this functional shift fast, then the patient can grow as normal. But if you leave this functional shift for too long, then the jaw can lock into the most anterior position. And when the patient stops growing, that is going to cause the true skeletal castri. So if you correct this fast, then maybe the patient have a chance to grow into the class 1 skeletal pattern. So functional shift, then we always correct it early. Okay, so this one consider functional shift. Patient have an initial contact on the central incisor, then the jaw will move forward. So this one we can correct it early, then we're back to class 1. Then hopefully this are stable and patient can grow into a class 1 malocclusion. Malocclusion class 1 is always easier than the class 2 and class 3. So if possible, if you intercept early, then patient have a class 1 skeletal pattern and class 1 malocclusion, which is easier to correct later. So you can look at this functional shift also. Sometimes you are not shifting forward, you can shift to the left or right. That's considered functional shift as well. So functional shift not only moving forward, they can shift to left and right, or sometimes even backward. So how are you going to check this functional shift left to right? So you can always ask the patient to open. So when they open, let's say the midline is back to the center. Then when they start closing the mouth, then we have an initial contact, and the jaw will shift to the left and right, which is cause the midline discrepancy. That's considered the functional shift to left and right. That's how I check. So you can ask the patient to open, and when they open wide enough, then the midline will back to the center, and high chance patient can have a functional shift. Then you can check. So what's the etiology? It can be so many factors, multifactorial for crossbite. So etiology can be persistence of the deciduous teeth. So if the deciduous teeth fail to go, they fail to exfoliate, and can cause a crossbite. Because the permanent teeth fail to come out, then sometimes cause crossbite. Crowding or abnormal displacement of 1 or more teeth. Sometimes 1 or more teeth can displace more labially or palatally, and can cause crossbite local, which is considered dental crossbite, and retarded development of maxilla in sagittal as well as the transverse direction. This one skeletal crossbite. If the jaw is developed not in the right proportions, let's say maxilla is too short or mandible is too long, or maxilla is too long, mandible too short, then that can cause crossbite, whether they are buccal or lingual or posterior or anterior. So narrow upper arch, typical castri, narrow upper arch, crossbite. Collapse of the upper arch, same thing. A lot of time we found in these cleft patients, they have an underdeveloped maxilla or narrow maxilla after the surgical corrections of the lips or the scar tissue will hold the development of the maxilla. This patient, a lot of time we have cross-bite. Unilateral hypo or hypoplastic growth of any jaw. So sometimes the jaw, one side can grow more than the other side. So for example, if your right side is growing more than the left side, then you'll see the patient have the asymmetrical jaw, which the jaw was shifted to the left side. So imagine now if you're free, you try to shift your jaw to the right side or left side. You can see the cross-bite. So if your development on both sides is not symmetrical, one side is growing more than the other side, and the jaw will be shifted to one side. That causes a cross-bite. Surgical discrepancy of the jaw, such as a forwardly positioned mandible. Again, this one can be the castration skeletal pattern, and this one causes a cross-bite. Presence of the habit such as the thumb sucking and the tongue thrusting can cause the lower tongue positions. So this one a bit arguable. A lot of people think if you have a tongue which is not on the palate, then the upper arch of the maxilla can be underdeveloped. So this one is typical for the thumb sucker. So if you put the thumb in the mouth and then push the tongue lower positions, then if the jaw on the upper without the tongue, then they're underdeveloped. Because if the tongue on the palate, then can expand the jaw a little bit. If the tongue on the lower jaw, then the lower jaw will be bigger than the upper jaw. So a lot of time we have this mouth breather, then they tend to have a long face, then longer lower jaw and lower bigger jaw. Then this one tend to have a crossbite. But this one is arguable. A lot of people, they have a habit refill your mouth, then they don't have these features. So if you look at the research, some will say yes, some will say no. But now we are more to training the patients position the tongue on the palate behind the upper incisor. So if you look at these functional appliance, most of the time they ask the patient to train the tongue positions, and hopefully the tongue on the upper palate, then they can develop the maxilla better. So what's the management? Management of the dental crossbite and skeletal crossbite, they are totally different things. Dental crossbite, like I say, they are easier. Then skeletal crossbite is difficult because it involves the jaw. So dental crossbite can be considered local crossbite. Then skeletal crossbite is usually general. They involve the whole jaw or single arch, or sometimes the whole jaw from the left to the right, like I say 7 to 7. That's difficult to correct. But local crossbite, and the 1 or 2 teeth, then easily to correct. So you want to correct the crossbite, then we're talking about management in primary teeth, early mixed dentitions, late dentitions, and permanent dentitions. Of course, a primary dentition, then we seldom do it. The reason why primary dentition, they are not permanent. So even though you correct the primary dentition, then maybe the secondary dentitions or permanent dentition might be developed in the crossbite also. But sometimes we do correct primary dentitions. Early mixed dentition is very common, especially the single tooth, 1 or 2 teeth involved. Then we usually correct in the early mixed dentitions or the late mixed dentitions. So this one is called interceptive orthodontic. Before they have all the permanent teeth, we go in to intercept, then that's considered interceptive orthodontic. So when the permanent dentition, which everything external bridge, exfoliated the decidus, then we go in, then they consider comprehensive orthodontic. Of course, sometimes you have to wait, sometimes you have to start early. So depends. Every case will be different. So the factor of anterior crossbite corrections, I think this one came out from the last ESOT exam, these questions. What's the factor to be considered for the treatment? So the first thing is treatment for the overbite, whether they have an overbite, too deep or too shallow. Then after correction, whether they're stable, you should have a positive overjet and overbite. We can talk about it one by one. Whether they have enough space or not. If you want to move the teeth buccolingually, you need space. Without space, you cannot move the teeth. So that's one of the considerations. So type of tooth movement. Are you going to move the teeth buccolingually using tipping movement or bodily movement, or sometimes even rotations? So it depends on what kind of movement you need, and you select the different appliance to do it. So maxillary incisor torque, So I think this one we go back to basic. So tipping movement, we are talking about tipping the crown. So if you're talking about incisive torque, then we are talking about the angulations or inclination of the root. So the crown, we are talking, we define it as tipping. Right, the root, then we define it as talking. Talking. So we can look at some cases, then easier to explain this. So first thing you can use, of course, the simple one can be tongue blade. So developing single tooth anterior crossbite can be successfully treated using the tongue blade. So this one is the most simple, less invasive. You can just give the patient some tongue blade. So this one you can easily find in the clinic or pharmacy. So you can buy it, or you can use the ice cream stick. So we can use it. So a lot of time they use one is not strong enough, then they tie it together. So you can see at the bottom left pictures. So they tie it with rubber band, usually 2 or 3 stick, then they make it strong enough. So the blade is made to rest on the mandibular tooth in a crossbite, and that acts as fulcrum. Then the patient is asked to rotate the oral part of the blade upward and forward. So use the lower as a fulcrum, then you push the upper teeth forward. So this continue about 1 to 2 hours for about 2 weeks. So not easy. Again, this one considered removable. You need the patient compliance. So of course, if the patient do it right, then the correction will happen. But this one usually involve 1 or 2 teeth. You can see the blade is not too wide. So if you have 1 or 2 teeth, maybe you can use an ice cream stick. If you have 2 or more teeth, then maybe you can use a normal tongue blade you can buy from a pharmacy.
Doctor, I think there's still some delay for some of the slides.
Some of the slide.
Maybe don't
Don't do too
don't need.
fast.
I mean this.
Okay, what can I do? The slides are moving.
Yeah, now still at tongue blade.
Still tongue blade.
Yeah.
Okay.
Maybe don't full screen. Just.
I don't know what can I do. Just let me log out again.
Yeah. I mean, just like this, I think is better.
Can you see my slide better?
Yeah, I think just put it like this.
Okay. So the second method, you can see was use this simple removable, which we call it Catalan's apparent for the lower anterior inclined back plane. So this inclined back plane, just like the functional, there are certain design, which is 45 degrees. So inclined back plane construct on the lower anterior teeth. Usually it's just a step-on appliance. So you can put on the lower incisor, but with the inclined back plane, which is about 45 degrees. So this inclined back plane can be made of acrylic or the cast metal, but usually acrylic is easier. I prefer to use acrylic because you can modify it later. If metal, then difficult to modify. The acrylic is not enough or too stiff, too shallow. You can always modify with the Koku. So it can be designed to treat the single tooth in the crossbite or sectional of the upper arch in the crossbite. So you can cater for one single tooth or sometimes even sectional, involve 4 incisors. So inclined back plane is designed to 45-degree angulations. It can be more, but usually we do about 45 degree more or less. Then which force the maxillary teeth in crossbite to the more labial position. So look at the bottom right pictures. You see the incisor, they are slide down in the inclined back plane. Whenever they bite, they tend to force the upper incisor forward. So using the back plane, which is about inclined 45 degree. So you can see on the bottom left pictures, you see how they design the Catalan's appliance. It's just a snap-on acrylic, usually from the canine to canine, with the inclined bite plane. That's how it works. Of course, you can add on later. If you think they are not enough, you can always add on some Kokyu acrylics to make it a bit stiffer if you want to move the anterior teeth forward further. So skeletal crossbite management can do it pre-adolescence, which is a primary the early mixed dentitions. Then you can use a palatal expander in the link dentitions, or you can do it surgically later. So you see in this in this slide, if you do it early, it will be easier. You only need the expander. But if you do it later, which everything is fixed, then a lot of time they involve surgical corrections. So primary dentitions, so if the patient have a primary dentitions and their crossbite, you can use a removable, removing the interference by occlusal grinding. You can grind the teeth a little bit, or even if you want to extract the primary incisor, because you have a secondary incisor coming out later. I seldom do it, because you want to extract the primary teeth, it can cause trauma to the patient. So you want to extract the teeth, but just because they're in a crossbite, then imagine the patient walking around without a central incisor for a few years, can cause a low SL extent. So this one I seldom do it. But if you're grinding a little bit, then to remove the interference, then this one possible. Sometimes if you want to just push the upper teeth and lower teeth forward and backward a little bit, you can do some occlusal adjustment. Posterior crossbite, if the intermaxillary width is satisfactory, then grinding the primary canine to eliminate the diffractive contact. Again, this one is to remove all the interference from the occlusions. So this I have to do it very carefully, but extractions of the teeth are seldom done. In both the molar and canine which are narrow, the expansion of the upper arch is indicated. If you're narrow arch, then maybe you can put the expander. But primary teeth, I seldom do it. But mixed dentitions, yeah, very common. So mixed dentition, it means you have the mixture between the permanent and deciduous teeth, then usually commence after your first molar erupted. So anterior crossbite, then mostly we're talking about permanent dentitions, which is the central incisor or lateral incisor of the permanent dentitions. So a lot of time, this lingually trapped incisor can be corrected by extracting the adjacent canine. So imagine, if you extract the canine, then you should give it sufficient space for the incisor to come forward. So if you not forget this serial extractions, if you not forget serial extractions, although we are not doing it anymore, but look at the sequence to extract CD4. C is the canine decidus, and D is the first decidus molar. Yeah, after that, extract the 4. So the first thing to extract is C because you want to give enough room for the alignment of the incisor. So if you extract the C decidus, you can give room for the alignment of the incisor. And so sometimes we extract the canine, we extract the decidus canine just to let the crossbite corrections. If sufficient space is available, then maxillary removal appliance is usually the best mechanism to correct the simple anterior crossbite. So you can use a simple removal appliance, like you design your removal appliance before. You can put a Z spring, or even you can put a anterior expansion screw that can correct the crossbite if they are not too difficult. Posterior crossbite, then you can use a removable or fixed appliance. So maxillary arch should be overexpanded and then held passively overexpanded position for approximately 3 months. So even though you correct this posterior crossbite, a lot of time we have to hold it about 3 months. So you let the bone remodel, then which need about 3 months. A lot of time this posterior crossbite correction, they are not stable. You need to hold it in positions for about 3 months. Just let it stabilize compared to anterior. So we'll expand later. That's because of skeletal. So if they're narrow arch, their expansion a lot of time is tilting the molar buccales. So when you're tilting, the molar is kind of considered the true skeletal expansion, which is less stable compared to the anterior. Anterior is more stable because they are positively over by the jet. So of course, expansion you can do with so many appliances. First one is a coffin spring. Then usually make a very thick wire, which are about 1.25 millimeters, stainless steel wire. If you bend the wire before, just for your information. Your Atom cup is about 0.7 millimeters. Sometimes you use 0.6 for the premolar, 0.7 for the molar. So this coffin spring is 1.25, which is about 2 times the size of your Atom clubs. So if you think your Atom club is very difficult to bend, then this coffin spring is more difficult. It's very thick. Then differential expansion in the molar and premolar region. So I seldom use coffin spring because they are difficult to adjust. Then they're unstable, lack of control on the molar, frequent activation needed, force applies vary. It's hard to measure how much expansion you put into patient's appliance, because you see this coffin spring is just like a U shape, so you can whiten the anterior and posterior differently. But how much force you put in is very difficult to measure. Of course, then later they come up with the W arch, which is easier to adjust. It's just like W. So again, they constructed of 1 millimeter inch of steel wire, then solder on the molar bands. So this one, you need something to attach to the T. A lot of times you can use an acrylic, then use Atoms or sometimes delta clubs, or you can put the molar bands on the 6s or the 4. So you need something to attach the 2. Then using this expander, so you can move both primary and permanently accelerate the rate of the normal expansion of the mid palatal sutures. So you see, we try to split the sutures, which is a mid palatal sutures, which will fuse about 10 to 11 years old. So if you do it before this age, then high chance you can split the palatal sutures. You can expand the jaw easily. But after the suture fuse, then it's difficult to expand the jaw again. So activated by simple opening of the apices of the W. So imagine the W, then the bottom of the apices, you can expand it a little bit. So how you do it, you just use the pliers. You can use the Atom pliers, just pull both sides opposite direction. That's how you whiten it or how you do the expansion. So the expansion should continue at the rate of 2 millimeters per month. So we talk about this, the rate of the movement of the T. We can move the T 1 millimeter per month. But if you count the left side and right side, one move 1 millimeter on each side, and we can get about 2 millimeter expansion per month. That's how we count it. Of course, later we have this W design, which is modified by putting the loops or helix on the 4 angle. Then we come up with this quad helix expander, which is quite famous in UK. So these are more flexible. Imagine this W, we have a helix on the corner, then we can expand or adjust the spring a bit more compared to without the helix. So this is a typical W design. Then we have this helix. So again, they're constructed with a 0.38 mils, which is close to 1 millimeters or slightly more than 1 millimeter thickness, and very strong spring or wires. Then spring capable of tender alveolar expansions of the molar as well as the premolar regions. So how they're going to expand the premolar regions? You see the bottom pictures. They expand the arm from the molar to the premolar. So by touching the premolar, when they expand the molar, they can expand the premolar as well. So this is more flexible because there are 4 loops. You can expand anterior and posterior differently. They can bring about skeletal expansion when used in young patients. So young patient, before the suture fuse, you can use this expander to do some true skeletal expansion, provided you can split the sutures. Cross elastic typically run from palatal aspect of the upper molar to the buccal aspect from molar. For scissor bite, opposite is allowed. So look at these bottom pictures. So you can correct the cross bite by attaching the rubber band. We call it cross rubber band, cross elastic, from the lingual side of the upper, then to the buccal side of the lower. By doing that, then we consider reciprocal pulling. So you can correct the cross bite on the left pictures. In the scissor bite, you can do the opposite. You can attach the rubber band from the buccal aspect of the upper into lingual aspect of the lower. Again, this is reciprocal pulling, so you can correct the scissor bite. So the indicator for the short period to correct the simple cross bite, usually this one for 1 or 2 T, you can do that. but sometimes involve the whole jaw is difficult. Okay, again, this one is effective in corrections of the unilateral crossbite. When it comes to bilateral crossbite, then a lot of time you need the expander to come in. Huh? So you want to expand both sides or correct both crossbite, both sides, then maybe better to use the expander rather than the cross elastic. A single crossbite or single side unilateral, then maybe you can use the rubber band. Knife tie palatal expander, this one very expensive. Huh? Same with the knife tie. Huh? I think if you look back your lecture, which is the dental material for orthodontic, we know that knife tie wires and the steel wires, they have different features. Knife tie wire, they usually have a shape memory. Huh? It means it can deform, then they can deflect back to the original shape. So you have this memory. So again, you can fix this in the expanded arch shape. Then whenever you squeeze in the patient arch, then they will expand the jaw because they have the shape memory. So again, look at the bottom right pictures. So this one is a knife tie expander. Expensive, but they're self-activating. So you don't have to activate anymore after you put in the patient mouth. Just let it work by itself. Compared to this steel expander, then you usually have to keep expanding, activating the appliance. Every few months, you have to take out this appliance. Then you have to widen the arch a little bit, then before you put in the patient mouth. Compared to this knife tie expander, then usually they'll continue working without activations because they're self-activated. They have the shape memory, so you can expand it by itself. Then they have usually temperature activated. So if you put in the mouth, then whenever they drink coffee or tea, then expander will work better compared to the cold environment. Huh? This one usually temperature sensitive, but expensive. Knife tie usually expensive. Steel is cheap, but you have to keep activating it. Huh? So this one every few months you take out, widen the jaw and put it back. This one you don't have to. So let's say a patient with the leg mixed conditions, then anterior crossbite, you can use tipping maxillary mandibility out crossbite using finger spring. Again, same thing, using the removable. You can use double helix, cantilever, Z spring, anterior bite plate to prevent any hindrance to the tooth movement. Okay, so this one, if you remember your exercise, you have a finger spring, Z spring, then sometimes anterior bite plane or posterior bite plane for the crossbite corrections. So fixed appliance also used in corrections, maxillary lingual arch with a finger spring used, posterior band and anterior bonder attachment with the round wires. Okay, look at the pictures. Huh? So this one removable. Huh? You can see the symbol removable. On the left side, we have a finger spring. And on the right side, we have this expansion screw. They work as a similar way. It's pushing the teeth forward and backward. In this case, we are pushing the lateral incisor on the bottom left pictures. And on the then we are using the screw to expand the upper right segment. Of course, you can put in something fixed. So this one we mentioned many times, removable. The problem is the compliance. So if patient not wearing it, nothing will happen. Even same thing for the expansion screw. Patient have to expand themselves by turning the screw maybe once a week. Then this one is called a fix. Fix, then you can take away the compliance. So same thing, you can put a finger spring, you can put the palatal arch. You see on the right pictures, they have the molar bands, then palatal arch, then with the same finger spring. Then the finger spring can correct the crossbite by pushing the incisor forward. Of course, you can use the fixed metal braces. On the left side, you can see the metal braces. You can put a bracket, then put the wire. You can correct the crossbite also. So the advantages for these fixed braces or any fixed appliance, they take away the compliance. Some people can prefer to use the functional appliance. The typical example is this flanger. So we talked about this before. They just have so many shield, plastic or wire. They just shield or block your labial surface and palatal surface, take away the tongue then the cheek and the lips, so the teeth can move without disturbance. So by doing that, then sometimes the crossbite can be corrected. Okay, so I think we mentioned before the suture, palatal suture will fuse after 11 years old or 10 to 11 years old. Then it become very tight. So the suture very tight, then you want to expand it, you have to speed the suture again. So you want to speed the suture, you need high force. You need high force. So a very heavy force is required to open the suture once they are fused. So you need about 10 to 20 pounds of pressures. So previously we mentioned, if you want to move the teeth, we need about 35 to 120 gram to move the teeth individually. If you do bodily movement, maybe 120. If you just do tipping movement, maybe 35 gram. 10 to 20 pounds, we are talking about 4,000 to 9,000 gram. So it's 100 times more than your two movement forces. So if you want to move the teeth, we are talking about 35 to 120. We are talking about extraordinary appliance, face mask, headgear. Then we are talking about maybe 300 gram, 400 gram, 600 gram. But if you want to speed the suture, we are talking about 1,000 gram, which is quite a heavy force. So usually a fixed appliance requires, because the force magnitude is large enough to displace the removable appliance. So if not something fixed, whenever you activate so heavily, then the appliance might be displaced or dislodged from the mouth. So you need something to fix on the tooth. So we have this rapid maxillary expander or rapid palatal expander. It involves the activation of at least 0.5 millimeter daily. So each turn, so you say if you activate the palatal screw, every turn is 0.25 millimeters. So 0.5 millimeters, it means you have to turn the screw twice a day. So every time you turn the screw, that will expand about 0.25. If you turn the screw twice, then you expand about 0.5 millimeter, which is very painful. So imagine if you keep activating this appliance for 1 week, then you can activate about 3.5 millimeter expansions, which is quite a lot. So a lot of time, this palatal expander or rapid maxillary expander, they cause median diastema of the central incisor because they split the sutures. You want to split the suture, then you have to be fast enough and strong enough. So if you do it too fast, then they create the median diastema on the central incisor. But don't worry about that. When you stop activating the appliance, the median diastema will be closed slowly. So the force is transmitted immediately to the teeth and then to the sutures. So again, you need something to fix on the tooth, then before the activation of the appliance. And hopefully, by fixing on the tooth, it will transmit the force to the sutures, which is about 10 to 20 pounds. Like I say, this is a very heavy force. The expansion occurs fast to a greater extent in the anterior portion of the palate because of buttressing effects of the other maxillary sutures in the posterior regions. So I think we talked about this expander before. So if the patient is too old, then sometimes we need this surgical assisted maxillary expansion. How do you do it? We use the burr to cut the sutures and they cut the buttress just to release the pressure or just to help us to expand the suture better. So a lot of times they cause a more expansion on the anterior portions because of buttress effect. Imagine these sutures or the maxilla, they are held by so many bone around. So usually when they expand, they tend to have a different expansion on different portions. So this one typical example for RME. You can see how they fix it. They fix it on the molar and the premolar. Then in the middle, they have the expansion screw. So if you turn the screw twice daily, so about 0.5 millimeter activations. So we do it about 1 to 2 weeks. You should call the patient back every week just to see how they're doing. So if you expand 3.5 millimeter per week, then that's how you're going to get. And look at the middle pictures. They have a median diastema. And look at the X-ray. You see the sutures and split. You have space in between the sutures. Then this suture is going to fill up with the bone again. So what we do is after we expand so much, they cause a median dystema, then we stop. Then we let the bone remodeling for about 3 months. So we hold these expanded positions about 3 months, and hopefully the bone will fill in the middle space. Then the T or the median dystema will close later. So this one again, consider heavy force. You have to do it very, very carefully. So imagine if you do it on an adult patient, you're not splitting the sutures, you keep activating this screw, you might push the teeth out from the bone. So you have to be very careful. I only do it for the young adult. So a lot of time for the old adult or they are quite old patients, then we need the surgery to come in to split the suture for us. So for old adult, then a lot of time we involve surgery. So young patient, you can use RME. So anterior crossbite factor to be considered. This one I think is repeated the previous slide. So you have to know whether they have enough space or not, then sufficient overbite and overjet, then position of the teeth, whether they are in the crooked positions or they are in the favorable positions. Occlusion, whether they have a class 1 or class 3. Class 3 is more difficult. When it involves skeletal discrepancy, they're always more difficult. Right? They're in their class 1 occlusion, they're easier to correct. Extend the root formations, like force wise for the root or the T with incomplete root formations. So for young patient, incomplete root formations, they recommend we use very light forces because you don't want to disturb the formation of the root. So we all know if the patient have a trauma, so sudden hit on the incisor, they can cause a devitalization of the teeth. Same with the ortho. If you use a heavy force, it might devitalize the central incisor, which will stop the root formations. That's why they recommend the light forces for all the incomplete root formations. So what is the method of correction of anterior crossbite? So we can occlusal adjustment, like say if anything have a initial contact, you can do some occlusal adjustment, take away the initial contact, then hopefully the teeth will develop in the better position. You can use an inclined backplane like the Catalans, or you can use a fixed appliance, metal braces or ceramic braces, something fixed, or even the palatal arch with a finger spring. Or you can use a tongue plate, which is quite easy. Then you can use an ice cream stick also, which I would prefer. Then you can use an expansion appliance with either the screw or cantilever spring. You can use Quahi legs, night tie, or even the RME or rapid maxillary expansion or palatal expansions. Okay, again, this one is anterior biplane, Catalans. We can use always extend to the posterior using the ADAM clamps to help for the retentions. Then we can have a simple removable appliance, which have the expansion screw on the posterior or palatal. So what's a factor to be considered if you come to posterior crossbite? Just now I talked about anterior crossbite. Now we move on to posterior crossbite. So the factor to be considered is available of the mesial distal space to correct the crossbite. Again, the first thing is a space. Without space, you cannot move the teeth. That's very simple, very logic. The position of the apical portions of the teeth after treatment. This should be in the same positions as that two in the normal occlusions. So this one I think is difficult to explain and imagine. So this one we are talking about the final position of the apex or the root positions. So imagine if the patient have a skeletal tree, we have a narrow maxilla, then there's a limitation how much you can expand the upper jaw. So for adult, you can always tip the tip buccally, then that's not the true expansion. That's why this one is less stable because the final position of the root is in the lingually tilted position. So high chance the patient might relapse after the correction. So compared to you have a lingually tilted at the beginning, and when you expand, the root is still in the good position. So when we're talking about the root position, we are talking about the skeletal, whether they are in the right size or they are in the wrong proportions. So I think this is difficult to explain. When you come back to school, maybe I can draw some picture for you. So type of two movement required, either the tipping or bordering movement. So we all know tipping is easier. So same thing, if the T is tipped back lingually, then we can just tip it back to Parker using a simple removable. But if you need bordering movement, then a lot of time you either split the sutures or you can use the fixed appliance to do that. So single two, then the crossbite. So using a single two crossbite, then both antagonist two are tipped out of the position. So it means just one single two is a peripheral position. So a lot of time this kind of malocclusion, you can correct using a simple appliance. You can use the bite elastic, like we showed you just now. You can use the elastic from the Parker to the lingual if there are one or two teeth involved. So these are cross-bite elastic. So disadvantage with this method require patient cooperation. Again, you need the patient to put on the rubber band itself. So compliance can be issue. Then require banding on the teeth. You need the molar bands or attachment on the tooth. You can use it on the molar, but you need some attachment. So a lot of time you have to put the molar bands or you have to put the bracket on the tooth surface. And over contraction and crossbite. Okay, functional interference is present by the occlusal equilibrium. Again, you can adjust the occlusions. You can trim whatever high bite or initial contact and take away the initial contact. Then hopefully the two will be corrected. The crossbite will be corrected. So appliance given after occlusal equilibrations are treatment of the bilateral contractions of maxillar arch, quad helix, W arch, RME, just as we discussed before. Quad helix is a 4 loops. You can expand it differently, anterior and posterior. W arch a bit more rigid. RME very heavy force, then with the expansion screw, which can activate about 0.5 millimeter every day. Treatment of the unilateral contraction of maxillary arch. And we can use removable plate, which is a simple upper removal appliance. Then again, we can use W arch, quad helix, coffin spring. But I think now we are using more quad helix and RME. If you look at the market, that we are doing more quad helix and the RME, just because they are easier and they are more flexible to adjust. Mandibular development contractions, you can use a quad helix appliance. Again, mandibular is difficult because they have the tongue, so it's very difficult to expand the lower jaw compared to the upper jaw. Upper jaw without the tongue, you can put any appliance on the palate, but the lower is difficult. A lot of time you want to expand the lower jaw, you have to try to bypass the tongue. That's difficult. Skeletal crossbite, it can be due to the narrow maxilla or narrow mandible. Then a lot of time, if they're fixed, they adult, then we need the skeletal corrections. So narrow maxilla is a mild case where not too bad. You can use a quad helix or W arch, or severe case, you can use RME, provided the suture is not too tight or not fully fused. Narrow mandible, then usually associated with the retromatic mandible. You can use a functional appliance. Functional appliance, I think we discussed this before. You will bring lower jaw forward, then that will correct a scissor bite. So very severe cases are treated by surgery. Class 2, Class 3, severe crossbite involve the whole jaw. Then a lot of time we need the surgical option. You need the oral surgeon to come in and help us. Okay, so you see for the left pictures, we have a unilateral posterior crossbite and maybe extended to the anterior a little bit. But this one can be corrected even without surgery. You can use the braces to do it. Then this patient maybe have a functional shift because you see you see the face a bit asymmetric. So this is adult. So even though you correct it now, maybe the jaw is not going back to the center. So if you correct it early, then maybe high chance the patient still can have a symmetrical jaw. So that's why I say if you have a crossbite, then maybe sometime you try to correct it when it's early stage. So if you look at the right side, then we have a typical class 2 and class 3 features. castry, then we usually have a bilateral crossbite, then plus the anterior and posterior. So when it comes to severe crossbite, then it's best to deal with surgery. Same with the lower pictures. I have a class 2. Class 2 features a lot of time we have a scissor bite on the posterior. This kind of patient, again, if they're too severe skeletal, then we deal with surgery. So I think with that, we finish our revisions. So maybe we go through some cases, then you can understand a bit better. Okay. Okay. All right. Okay. Can you see my mouse?
Okay.
Okay. So you see this case. What do you think? Is that skeletal or dental? Crossbite.
Dental.
Why you say dental? Because it involves maybe 1 or 2 teeth in crossbite. But I would say these patients a bit of both, a bit of skeletal, and also a bit of local. So dental alveolar, it means they are involved 1 or 2 teeth, which is simple. But this patient also have a tendency of castry, a little bit, not too bad. But you're right, I think this one is mostly dental. So if you see the 1, 2 in the crossbite, then the left side have the 2, 2 in the crossbite. Then we have a bit of castry skeletal pattern. Then we look at the crowding, that's quite crowded. Then the 1, 2, and 2, 2 are better displaced. So I think you look back to the factor to be considerate. Then we're talking about space. The first thing is space. Whether you have enough space to move the teeth buccolingually. So do you think we have enough space for these patients? No, because the 1, 2 and the 2, 2 is blocked by the central incisor in the canine. So in this case, you not enough space to move the teeth labially. Even though you put the Z spring or you put the expansion screw, then they're not going to happen because you got not enough space. So in order to correct the crossbite, then maybe the first thing we have to consider to create the space first. How we create the space is by extraction. So when it comes to severe crowding or too much of crowding, moderate crowding, then we need the space to correct the crossbite. Then we do extractions. So in this case, we extract the premolar to gain the space for the correction of the crossbite. Again, after correction, then you have to look at whether they're stable or not. You have to look at the overjet and overbite. So a stable corrections of the crossbite must have the positive overjet and overbite. Without these two things, the result not stable. So imagine this patient have the anterior open bite also. Maybe even after correct it, if they don't have a positive overbite, then the teeth can fall back again. So you need something positive overbite and overjet to hold the teeth in position. So for braces, we always aim for positive overbite and overjet for the stable occlusions. Okay, this one no crossbite. Okay, no crossbite. No. Okay. All right. Okay. So you see this one maybe have the upper left two in the crossbite. Okay. So this one, if you want to correct it, maybe you can do the simple removal. If you don't want to correct the other malocclusion, then maybe you can use simple Z spring to push the lateral incisor forward, because the space is not too bad, even though they are a little bit limited, but you can try. Okay, this one, oh, skip that. Okay, all right. Okay, you see this case? This case is more to both. It can be dental and skeletal. Use the dental crossbite on the 1, 2, and 2, 2. But this patient also have tendency of castry. So this patient, again, we take out some premolars, 4 premolar. Then after that, we correct the crossbite because there's limited space available. Okay, class 2, the tendency of scissor bite. So you have to look at it. This one use functional to bring the teeth back. Then after that, plus extractions or premolar to correct it. Okay, no crossbite. This one no crossbite. Okay. Okay, functional. Okay. So what do you think about this crossbite? So this crossbite involve lateral incisor, then the lateral incisor. This I consider reverse overjet. Reverse overjet. Crossbite involve the 1-2 to 2-2. So this one I think is more to skeletal because patient have the skeletal tree. So this one difficult to correct. Even if you use a simple removable, then maybe it's not stable. Because imagine if you tip the upper incisor forward too much, then maybe they will end up anterior open right. So this case, I end up doing the fixed braces plus 4 extractions of premolars. And after that, you can correct the midline, then the crossbite, everything together. So sometimes if the lower teeth stick out too much, then you have to bring it back using the fixed braces. So this one we do fixed braces, then we do camouflage because they have the skeletal tree. Same, this one crossbite is due to skeletal. You see the lower jaw is sticking out a bit too much. Then crossing the crossbite on the anterior. You see the more severe the skeletal tree, then there are more teeth involved in the crossbite. So when it comes to severe crossbite, then it's best to deal with the fixed braces. So this time we take out 2 lower premolar, then we tilt the teeth back. That's how we correct the crossbite. And the upper, we just do non-extraction and pushing the upper teeth forward a little bit. That's how we correct the crossbite. Okay, so this one also the same thing. This one is skeletal castry. Skeletal castry, you see the involve the crossbite. They form the canine, and to the other side, canine or premolar. So this one considered skeletal crossbite. So when it comes to skeletal crossbite, a lot of time we try to deal with the fixed braces or sometimes reverse pull headgear, even they're still young. Okay, and their crossbite. So this one same thing. You see the crossbite involve 4 incisor. But this patient, you look at the buccal from canine to the molar, they are not in the crossbite. So only the anterior 4 incisor in the crossbite. So this is patients, we call it pseudocastry. Patient can have an initial contact on the central incisor, then the jaw will slide forward a little bit. This kind of patient, maybe we can change the crossbite or correct the crossbite, then hopefully the jaw will develop into the better ratio or proportion. So this one, you can use a simple removable or you can use a fixed braces if you want to have a bodily movement. If you use a removable, then most of the time you're tipping the incisor forward. So you see the incisor are trapped behind the lower incisor. So you can use a posterior bite plane to pop the bite open. You can use a simple removable appliance just to push the incisor forward by using a tipping movement. Okay, see this one is skeletal crossbite, skeletal crossbite. Okay, same thing. This one is due to the space and a little bit of skeletal, then causing a crossbite incisor, lateral incisor to lateral incisor. This one you can use the fixed braces to correct it. Or you can use a removable. If you want to use a removable, maybe you can use a Holly on the lower, closing the lower gap by pushing the lower tip backward. Then maybe you can correct the crossbite also. Okay, this one again is skeletal. You see how many teeth that involved from the canine to the other side, maybe to the molar. So they're all crossbite. And this one is anterior, posterior, and unilateral posterior crossbite. Again, this one we deal with the fixed braces because it involves skeletal. Same thing. So this one is more to a bit of both skeletal and dental. So this one have a castry skeletal pattern, and I also have a local crossbite from the incisor to the premolar. I look at the molar, they're okay. So this one we also deal with the fixed braces. Same thing. When it comes to severe reverse bite or severe crossbite with a skeletal tree, then we have to do some camouflage treatment And most of the time, we're just tilting the teeth back. You see the lower incisor tilt back, upper incisor tilt forward. That's how we correct the crossbite with the fixed braces. Same thing, see the crossbite involve, how many teeth involved? Canine to canine. So this one also consider dental and skeletal, mostly more to skeletal. So with the fixed braces to correct it by tilting the ankle back. You see the lower incisor lean back so much, the upper incisor lean forward, camouflage. So when it comes to too severe crossbite, anterior, you see the whole jaw is in the crossbite, 7 to 7. So this one is considered severe skeletal tree. When it comes to severe skeletal tree, then a lot of time we have to deal with surgery. So this one considered severe crossbite, anterior, posterior, bilateral. So this one we do surgery, jaw surgery. So first thing, you straighten the teeth. Then after that, the surgeon will come in and cut the jaw. Then we'll push the jaw back, upper jaw forward, lower jaw backward. And they'll correct the crossbite. Of course, the advantage for surgery, you will change the face rather than the teeth. So you see at the end, the face will look better. So same thing, this is severe crossbite. Okay, when it comes to asymmetry, just now we discussed about the unilateral and bilateral crossbite. So which one is easier? It's a bit difficult to judge based on the case itself. And if you see this case, we have an asymmetry crossbite from the incisor to the molar. This one is caused by the skeletal asymmetry. This one, no initial contact, no functional shift. So if you know functional shift, it's more difficult to treat. If the functional shift, it means the jaw is in the right position. It's just because of the teeth. That's why the jaw is shifted to one side when they're back together. But when you have without any functional shift, no initial contact, there's genuine bite, then it's more difficult to correct because they don't have initial contact. No matter what you do, the jaw is still asymmetric. When it comes to this case, then again, it needs surgery to correct it. So same thing, I line up the teeth, then after that the surgeon will cut the jaw, and just to push the mandible back to the center. See, after the corrections, the midline will back to the center, the crossbite will be corrected. Again, this one involves the jaw surgery. How they do it? They just cut the jaw one side more than the other side. For example, you want to move the jaw back to the center, and the jaw is shifted to the right side. When you do the surgery, you cut more bone on the left side compared to the right side. So you can move the jaw back to the center. That's how we correct the jaw asymmetry. Of course, when the patient is a bit younger, you can use this rapid maxillary expander. You can see I have an expander on the posterior region. And at the same time, I have this face mask just to reverse the bite. This case we discussed before last week. We use the face mask to reverse the overjet and reverse the crossbite. Okay, and this one can achieve some skeletal changes. So you see from the class 3, and raising face mask, and it becomes slightly more class 1. Same thing, you see this one skeletal class 3, when the patient is still young, we can put in the expander, then plus a face mask, and maybe if you're lucky, then the patient becomes slightly class 2, or if not, then more to class 1. And at the same time, we can reverse the crossbite. Okay, this is before and after face mask. When patient have the mixed dentition, you can do the face mask to reverse crossbite. Open bite, no. Okay, gum surgery. Okay. Okay. But now we have a tack or a mini screw, so we can mimic what we can do by surgery. For a typical example, so this is skeletal tree, severe skeletal tree. Then patient wants surgery, so we can do the tack or mini screw just to reverse a crossbite. Even though they are considered surgical case, we can still achieve a positive overbite overjet at the end. Okay. Okay, no. This one. Okay, so look at this. Look at this. It's only have a crossbite on the right side, lateral incisor. So lateral incisor, not enough space. But this patient, you see, have the midline discrepancy on the upper. The midline is off to the right side because of the crowding. So in this case, I do non-extractions. I squeeze in the lateral incisor by doing some expansion on the upper. So by squeezing in the lateral incisor, the midline will back to the center. So this one crossbite correction, but not taking out any teeth. That's why purely by expansion. You can see at the end, you see the arch width left and right. They are bigger than before. We expand the upper jaw a little bit. So sometimes when it comes to mouth crowding, you don't have to do extraction. You can just do expansion using expander, core helix, RME, or even using an arch wire. So there's a expansion. You can see at the end how much you expand the upper jaw. So this one initially is a V shape. Then after braces, they become a round shape. So that's how we expand. When I expand the jaw, the teeth will go sideways, and at the same time, the front teeth will go forward a little bit. So it end up become a bigger circus. Okay, that's how we do the expansion. So you can correct the crossbite, at the same time the crowding. Okay, so you see this one is a very interesting case. You see the patient have a crossbite on the right side from lateral incisor extending to the molar, and at the same time this patient have the functional shift. You see the lower mandible is shift to the right side whenever the patient bite. So after we correct the crossbite, you see the midline is back to the center. So imagine if you do it too late, then the patient will lock the jaw on the right positions. Then when everything stops growing, then this jaw is fixed. Then the patient will end up asymmetrical jaw. So when it comes to functional shift, then you try to correct it faster so that the jaw can grow in the better positions. So this one we do some expansion. You see in the upper, how much I expand from the narrow arch on the right side, then we expand it to the full size again. So that's what we call expansion. Of course, this one I use core helix. I use core helix to do. Simple crossbite on the lateral incisor, a little bit crowding. This one I can do in non-extractions. Non-extraction. You just put the wires, expand the jaw a little bit. You can correct the crossbite. Okay. So this one also crossbite on the incisor. This one I do expansion as well. You see, I do expansion. How much I expand? After expansion, you push the upper incisor forward. At the same time, you widen the arch a little bit. And by doing that, then the upper and lower jaw will be matched. Okay, look at this. Okay. Next. Okay. All right. I just want to emphasize the crossbite correction, early crossbite corrections. It's very important. So look at this case. We have a patient have a crossbite on the central incisor by causing the forward displacement of the lower jaw. So we have initial contact on the central incisor, and have displacement of the lower incisor. So whenever patient bite, it keep pushing the lower incisor forward. So this lower incisor is considered traumatized. You can see the gum margin on the lower is already recessions, gum recessions, and the tooth is very mobile. So if you leave this for a few years, then might end up losing the central incisor. So when it comes to this situation, you have to act fast before the permanent central incisor becoming too loose. So whenever they are present in the clinic with the crossbite initial contact, then you intercept fast. How can you do it? You just put in the simple removal, pushing the incisor forward, then achieve a positive overbite and overjet, and this is considered stable corrections. And you let the patient to grow further until they're in the permanent dentition before we start fixed braces just to tidy up the occlusion a little bit later. But imagine if you leave this for years, then at the end, maybe I have to extract the central incisor. So act fast before it's too late. Of course, when the patient become adult, then we can always use a fixed braces to correct the simple crossbite on the right side. So this one I use removable because they are still in the mixed dentition. You can see the lower dentitus is still present. Of course, when you come to crossbite, and sometimes it's difficult for you to do any fillings. Let's say there are obtrusions due to long-term crossbite and have attritions on the central incisor. Without correcting this crossbite, how are you going to build up the incisor edge? You can't do it because across a lot of high bite, then my fracture the incisor will build up. So in this case, we need auto to correct it, auto to correct the crossbite. Then after that, you can do the nice filling to patch it up. So crossbite, you have to watch out. They are not only damaging the teeth, they're also damaging the gum, and they're also damaging the ligament, the surrounding supporting structures. So you have to look at it carefully. Okay. Right, crossbite. You see how much a crossbite will cause the damage to the periodontitis patients. So if your supporting structure is weakened, you have a crossbite, you see that how much damage can cause the lower incisor. So this lower incisor cannot be saved. At the end, we have to take it out. So we take it out and close the gap with braces. So if you imagine if you correct the crossbite early, then maybe you don't have to come to these situations. You don't have to extract the central incisor. Okay. Fixed retainer. Okay. All right. Okay. So you see the left side. This patient left side have a crossbite. Then this one considered skeletal. So we have a too narrow upper arch and too wide lower arch. Then what we do, we expand the upper left and then we constrict the lower left. And how we do it? We take out the T also. So we take out some T, we can constrict the arch. At the same time, we can expand the arch. So at the end, the patient, we can correct the crossbite. Okay, so you see this functional shift? You see initially the center line is off because of this crossbite on the canine. That's what we call the occlusal interference. So sometimes some people, they are more aggressive, can take a burr to grind off the cup tips on the canine, take away the occlusal interference, then the jaw will shift it back to the center. Of course, you can do it with braces also. You can align the teeth, and at the same time, you can remove the occlusal interference by doing some intrusions of this canine. Then after that, the center line will back to the center when you correct the crossbite. Okay, this one, no, we're not going to discuss this. Okay. Okay, so you see this is typical, just a dental crossbite. You see the 1-3 and the 2-3 in the crossbite, but the rest is in the 9th class 1. So this patient have the lingually positioned canine. The canine always erupted palatally, and they come forward a little bit. But when they are blocked, then they'll cause a crossbite. So this one, crossbite, can be simply deal with the removable appliance. You can just put a jack spring on the palate and push the canine forward or buccally, provided enough space available. At the end, you have a positive overbite over jet. So this one palatally displaced, you can always tilt the canine forward a little bit using the simple tipping movement by removable braces. Then at the end, we look at the overjet and overbite. If they're both positive, then they're considered stable. Okay, scissor bite. So scissor bite is difficult to correct. I would say scissor bite is still considered one of the most difficult malocclusion to correct with braces. So if it's just one tooth in scissor bite, so for this example, it's just on the molars in the scissor bite. So you see how much the molar will flat out. So this one we can correct with braces, provided you can tilt this molar back into occlusions. So at the end, you can correct this scissor bite. How I do it? I use cross elastic, like just now I show you in the pictures. 1, 2, I can do some cross elastic for the buccal on the molar, upper molar, to the lingual of the lower molar. By doing this reciprocal pulling, then we can correct this scissor bite, provided there are not too many teeth involved. But when you come to severe scissor bite, you see the whole segment involve the maybe 6 and 7. So this one I consider difficult scissor bite. So you see the whole segment is hanging down and causing the trauma or damage to the lower buccal gingiva. So this kind of crossbite, you cannot correct with a rubber band. You need what we call the surgery or sometimes mini screw to come in to correct it. You see in this case, I use a mini screw on the lower and at the upper also. Upper and lower using mini screw. Why I use mini screw? Because I need to intrude the molar before I correct the scissor bite. Because scissor bite is locked behind the upper molar. So you see how much expansion I do. You see the lower, I use the wire to expand the lower jaw. And by doing that, then it will bring the molar buccally. And the upper also, you see carefully have a mini screw in the middle. Then this mini screw is going to constrict the arch by pulling the molar inward a little bit. By doing that, I can correct the scissor bite. So you see this one, I think we mentioned before, even a cross bite, it causes so much damage, not only to the teeth. You see how much the teeth that I treated? You leave it for years. Sometimes you're not careful, it will cause the part exposed, then patient might need a root canal. So even though you want to do the filling, it's not possible. You want to do the crown, you have to cut the whole tooth away. You have to change the angle so much, it might involve the root canal also. So you can use a simple upper braces just to reverse the bite. After you reverse the bite, then you can put the composite on it. So nicely done. And the end patient will be happy with the aesthetic result. But without braces, this cannot be achieved. So crossbite cause damage to the teeth and surrounding structures. You see how much the lower incisor, the gum recession, and causing the black triangle. So if you can do it early, then this can be prevented. Okay, I think I have no other case to show you. Okay, all right, maybe this is the last one. So you see this one skeletal castrate, then with the lateral incisor in the crossbite. So this one we corrected with braces plus the extraction also. Yeah, I think I have discussed all the treatment options for crossbite. Do you have any question to ask me?
Doctor, I have one question.
Yeah.
Like for in early mixed dentition that we require arch expansion, and then we expand the arch with the appliance first, then we continue with the fixed appliance to align the teeth, even if it's in early mixed dentition also.
If early mixed dentition, the reason why you want to expand the jaw is because you don't want the crossbite to cause the disturbance to your growth. Because if your jaw is locked in one position, they might develop the jaw in asymmetrical way. So you want to prevent that. That's why you use the expander to correct whatever crossbite is possible. But the patient is not ready to fix braces because the patient is still in the mixed dentition. So after you expand the jaw, you hold, then you monitor for a few years. When a patient about 12 to 13 years old, when have all dentitions established, permanent dentition established, then you go for fixed braces later.
Means we hold without any appliance, like just
Yeah. You just you just leave it to observe, huh? Because the patient is not ready for the fix. You don't want to put the fix on the mixed conditions. So fixed braces, we always do it when the patient is an adult T. Of course, if you leave it too late, you leave the crossbite without correction. Let's say mixed condition, you don't want to intercept. You leave it grow until they are older, then you become a skeletal problem. How are you going to deal with skeletal? Surgery. So you always try to correct the crossbite early because you want to prevent the skeletal problem later.
Okay, understood. Thank you.
Yeah. Any further questions? So you can see the crossbite is not that easy. Huh? We don't deal with the crossbite just alone. A lot of time the crossbite happen in the crowding, rotations, the anterior, posterior, unilateral, bilateral. So we have to treat the patient malocclusion as a whole. Like I say, we have to see the patient as a whole, not only on a particular spot. So you have to see the whole picture before they finalize the treatment plan for the patients. But if you see the crossbite, then in the mixed condition, if possible, yeah, you try to correct it early, especially if they have functional shift. Any more questions before we end these sessions? No? No questions? If no question, then maybe we'll end here. Then just sign your attendance before we close the sessions.
All right.
Okay, so the next week, what you want to do next week? I think I basically cover all the topic you mentioned. So if you have no further topic you want to revise, then maybe I will do some new topic for you, even though it's not in the syllable. Then maybe I will think of other topic. Maybe I think you should know before you go into private practice. If that's okay with you, or you want to know how to become orthodontist, then maybe we can talk about it also. Because I don't know what to teach you anymore. I think I cover all the topic. Then you have all the lectures done. Then if you have no further thing you want to revise, then maybe we'll go for a new topic. Yeah, what do you think? What you want?
I think let me ask the class. So either maybe a continued revision or further topics, right?
Yeah.
Okay.
If you want a new topic, then maybe I can give you a few. They can choose according to your interest. Yeah. Okay, you let me know, class rep, okay? Okay. All right. I'll see you soon next week. Yeah. Bye.
Bye.